Okay. Okay, we have two more years to ask about. 2018, there's an excise tax on certain health plans.
Right. This was the so-called tax on the so-called Cadillac insurance plans. In other words, high cost, high benefit insurance plans. And this will kick in 2018, but only for insurance plans that have an annual cost in excess of $10,200 for an individual or $27,500 for a family. That will not affect the vast majority of people in our audience, a vast majority of people in Minnesota. It's only a tax on the very high-end plans, and it doesn't even take effect till 2018. But that will also help pay for the costs in this bill.
Okay. And finally, with clear vision, we look at 2020.
Right.
And what ends in 2020?
2020 is a significant date because something of tremendous interest, I think, to a lot of our listeners, the so-called donut hole in the Medicare Part D prescription drug program. Folks probably know and have firsthand experience with this, that if you bump up against a certain dollar limit, you continue to have to pay your premium, but you don't get any Part D coverage until your Part D expenses exceed a certain amount. The other side of the donut hole, then full coverage resumes. And so by 2020, this bill is going to eliminate that donut hole. But it does something else. More immediately this year, if you bump up against the donut hole, you're going to be eligible for a one-time payment of $250. And that will help. And then the years from 2011 to 2020, gradually the donut hole will be eliminated so that it's gone completely by 2020. You'll continue to get full Part D coverage for the premiums that you pay.
Okay. So we see that this gets put in stages. In case we've gone too fast for any of our viewers, we're going to be covering some of these same points in just a little bit different way in the time that we have left. So we've glided into talking about retirees with the donut hole. The high prescriptions expenses, as you mentioned. So the $250 one-time payment.
Right.
Now there is a difference now. I've read recently about the Medicare Part D. The open enrollment period has changed. It's been moved up, so that now that begins October 15th and goes to December 7th, and that's the open enrollment period where people who are in Medicare Part D can examine other policies and to see if we're getting the biggest bang for our buck.
Right.
And so that open enrollment period starts a little sooner. It edges away from the holidays and having to make a decision by the 31st of December and so forth. So. And I've done a lot of reading on the healthcare Part D and other parts of this whole law, and boom, this fact just came to me on Friday. So that's another reason why we have to keep on monitoring.
Yes.
Now, big subject for retirees, Medicare Advantage plans. Let's set the stage for that.
Well, let's describe. Some people may not know what Medicare Part D Medicare Advantage is. This program was created by Congress basically at the insistence of the insurance industry because they told Congress, they said, look, we can deliver a basic package of Medicare benefits at lower cost than the federal government. But unfortunately, it turns out that is not the case. The Congressional Budget Office and other analysts who've looked at the Medicare Advantage program have in fact discovered that its costs are running at about 14 to 15% higher than traditional Medicare. And so this legislation revamps Medicare Advantage. But interestingly, there was much said during the debate about this bill that we were taking $500 billion out of the Medicare program. That is not true. What is changing is that the reimbursement structure, that these private insurance companies who have been collecting this 15% bonus for the Medicare Advantage program aren't going to be able to continue doing that. and that in fact it's going to reduce premium costs for people in traditional Medicare. Nobody is going to necessarily get less care than they have received. It doesn't do anything to change the basic package of Medicare benefits, which the Medicare Advantage plans are obligated to offer. The other thing we should say about Medicare Advantage is that many people who have been in those plans discover sometimes that they end up paying high deductibles and high out-of-pocket costs, and the reason those are built in is to discourage folks with serious illnesses from signing up for those plans. But sometimes they don't catch everyone, and some people have ended up in those plans with a catastrophic illness and found that they had to pay more out-of-pocket under Medicare Advantage than they would have had they been in the straight Medicare program. So that's going to change with this legislation, and it's actually going to help extend the solvency also of Medicare by meaning that we're spending less money for insurance companies and putting more money into Medicare.
So we don't have a government-run health care plan. This is private companies in the open market, and they will have to make some changes to meet the competition.
That's right. This bill, the centerpiece of it, it was never a government takeover of health care. And that was just so much political hyperbole that was out there. I think the reality is it's still centered largely on private insurance. Yes, there are some changes to Medicare. Yes, there is an expansion of Medicaid to cover many of the people that the private insurance companies don't want to cover. And so it's sort of a balance of those two things. But for anyone really to characterize this new law as a government takeover of health care, that really misses the mark and is, I think, very inaccurate.
Okay. Let's talk about preventive care. How are seniors helped with preventive care, such as screenings for cancer?
Well, one of the things down the road here, seniors are going to be able to get screenings for cancer and other preventive health care services that will be wrapped into these plans that will be offered through the exchanges and with no out-of-pocket costs. The reasoning in this is that we want to catch problems that people have early when they're treatable and they're affordable to take care of and they have a better outcome, rather than waiting, denying you the screening for the problem that you may have, and waiting until it becomes something that is life-threatening or so much more serious and inevitably ends up costing 3, 4, 5 times more to treat it then than if you had caught it early.
An ounce of prevention
is a pound of cure, and that's the realization of that, I think, is recognized in this bill.
Okay. Now, with retirees, as we get older, we go to the doctor more often, and we have more prescriptions.
Right.
So a major consideration for retirees is the accumulation of medical expenses over many years.
Right.
So what does the Healthcare Reform Act say about lifetime limits?
It basically abolishes those caps on lifetime limits. For example, let's say you've had insurance coverage for 30 years with one carrier. All of a sudden you're diagnosed with a catastrophic illness. But the insurance company says, you've bumped up against $100,000 of expenditures, we're dropping you. Under this new law, they are not going to be able to do that anymore. It abolishes the lifetime caps. And it also does something else with respect to premiums. It sets some guidelines for premium review. This is an issue for seniors because as we all get older and sometimes less healthy, as you mentioned, Dan, we end up having higher medical expenditures. And insurance companies have been able to use that justification to sometimes enact rate increases that are sometimes far beyond what they should be and are in the category of exorbitant. Well, now in this, we're going to have a rate review mechanism so that when insurance companies are choosing to raise premiums, those premium increases are going to be reviewed by a federal agency.
Is there something in the law, in the rates regarding males and females?
That's right. One of the big complaints with the current insurance regime is that insurance companies have basically been able to discriminate